I think going ahead with the tricky situations in smile, mysteries in smile, I think we have got none other than our superstar, Dr. Sri Ganesh. I think to introduce him once again, I hand over to my co-moderator, Dr. Sonu. Sonu, unmute.
Shri needs no introduction, and Shri is again. Is my slide visible? Shri Ganesh is the chairman and managing director of the Netradhama Super Speciality Eye Hospital, the first NABH accredited eye hospital. Main interest, phacoemulsification and refractive surgery. Numerous publications, more than 100 live surgeries, and numerous awards. Honorary FRCS, honorary Doctor of Science by the Rajiv Gandhi University of Health Sciences. And I think he has huge publications, medals, awards, which cannot be listed here. All to you, Shri Ganesh, for this wonderful webinar.
Thank you, Sonu. Good evening, dear friends, and I would like to thank the AIOS Scientific Committee, Dr. Partha Biswas and Dr. Krishna Prasad Pudlu for inviting me to this very interesting webinar. And then I would be speaking on the mysteries in smile, on retained lenticule post-smile cases, and then how to handle them. So is my screen visible?
Yeah.
Yeah. So I am a consultant to Carl Zeiss Meditech, and I've been doing smile since 2012 now. 8 years, more than 8,000 procedures. So we have had certain very interesting, challenging cases, and retained lenticule is something which can present as a mystery. And I would like to share with you 2 cases. So, and also the approaches. The first approach is exploration of pocket through the previous smile incision. And this can be attempted after the corneal visibility improves, usually a week or so. And you have to review the primary video, surgical video, and you should see that the laser has fired and smoothly in all 4 stages, and the lenticule has been created properly. If it is not, if there are black spots and all that, then there's no point in exploring. And like the previous, like Dr. Maipal and Ramurthy discussed, you can just do a surface ablation. You should also do an ASOCT, which can give you definite clues about the location of the retained lenticule. So let us go on to case number 1. This was a 24-year-old male who was operated by my colleague. I was traveling, and this was one of the visiting consultants. He tried doing smile in the right eye. He said he dissected the lenticule and he separated the lenticule completely, but he was not able to grab the lenticule. And he tried multiple times, but he was not able to get the lenticule, so he abandoned it. And then the uncorrected vision was 20/40. Best corrected vision showed some mixed astigmatism, and it was not improving. Patient was very upset. Surgeon also was just starting out with smile, so he was also very afraid. And then they were waiting for me. And well, this is how it presented. The topography, you can see the topography was showing a lot of irregularity, inferior steepening. Here you can see that this flattening, and also beyond that some steepening. It's even not recording because here this area was quite steep. And on the topography, you can see that there is a hump here. This was inferiorly. You can see that there is an elevation here. So it was a very irregular cornea. And then we thought we'll take it up for exploration because he had not removed the lenticule. And I'll show you the video. So I opened the previous incision. You can see that. And then went in. But inferiorly, there was something there. You can see that. So I went below and then dissected that portion completely. This is what you see on OCT. And I thought it was like maybe a fragment of the lenticule, but when I removed it and spread it out, it was the complete lenticule. So what had happened is he had dissected the lenticule, but he had pushed it down. So that's why he was not able to grab it with the microforceps. And he thought that he was not able to remove the lenticule. The whole lenticule had crumpled and gone inferiorly, and it was causing irregularity. And this was the resurgery at 7 weeks. And you can see pre-op, this was the topography. It was very irregular. If you look at the irregularity, is 7.2 at the 3 mm zone and 8.7 at the 5 mm zone. Very irregular cornea, loss of best corrected vision. Post-op, you can see that the cornea has become regular, the central flattening. The irregularity index is 1.3, which is normal on the op scan. If it's below 1.5, and patient improved to 6 parts uncorrected vision. So this is, final uncorrected vision was 6/6 2020. And best corrected was 2016 with very small cylinder. So this was the pre-op OCT, which showed this hump here, and then post-op you can see that that has gone. Cornea is very smooth. So exploration can be done in experienced hands, and patient can recover very well, though it looks a little scary. The other option is open exploration with the Circle software. Circle software basically is an enhancement solution for SMILE, and it allows the surgeon to convert the SMILE cap into a flap. And it has where you can plan the following incision. One is the lamellar ring, and second is the side cut with the hinge, and third is the junctional cut, which connects the inner part of the interface. And we used it to treat irregular astigmatism as a consequence of complicated SMILE surgery, and I'll share this mystery. So indications, when would you like to use Circle software for exploration? If there is irregular topography, the AIOS OCT is inconclusive. You can't see anything on the, it looks pretty normal. And even if the AIOS OCT shows multiple planes of entry, you don't know which plane to go into, then that's when you use the Circle software. This was a case of incomplete lenticule dissection to a large, because of a large black patch. And we were discussing black patches. This was a 33-year-old female. SMILE procedure, both eyes, right eye went on very well, smoothly. Left eye, there was complicated surgery because of a black patch. And post-op, the best corrected vision was only improving to 20/40 parts with myopic astigmatism, -1 with -1 at 125, but she was not improving, only 20/40 parts. The right eye was good, left eye was bad. She was comparing, and she had a lot of discomfort. This is the primary surgery. So you can see there's a large black spot here. Now, black spots can occur because of dryness, because of meibomian secretion, etc. And you can see that the dissection, though we went ahead because it was not in the center, not in the visual axis, I went ahead and did the dissection. You can see there is a little bit of difficulty while dissecting at the area of the black spot. But I complete the dissection, I'm able to remove the lenticule, I inspect the lenticule also, and you can see that the whole lenticule has come out. And you can see, so this is a mystery. The whole lenticule has come out as such. And then, but the topography showed this picture. There was a central steepening here. You can see this area was steep. It's like a central island in the old LASIK machines, what you used to get. Central steepening and irregularity in the center, loss of best corrected vision. We did the AIOS OCT also. If you look at the AIOS OCT, it was unremarkable. I mean, you can see the interface here. There is no lenticule as such. We couldn't make out any remnants. If you look at the epithelial maps also, kind of unremarkable. You can see there is some amount of thinning of the epithelium in this area, but largely okay. And if you look at the pachymetry map also, it's fairly uniform. So what to do? And we were wondering what to do, whether we should do a topo link for this patient and treat that central area, which is irregular. Then I decided maybe the irregularities in the interface. So if we treat the surface, it may not really help the patient. It's better to explore and treat the interface. So on slit lamp examination, I could see a small ridge like that here. You see this area? So that was there on retroillumination. So that's why we decided to use the Circle software. So this is the Circle software where the cap is converted to a flap. So the nasal hinge, I lift it up and you can see there's a sliver of tissue there. Can you see that? So as I'm just pushing, there's a very thin, maybe like about 10-15 microns tissue which is stuck. So it is part of the lenticule was stuck and the whole lenticule has not come out, but a part of it, maybe like 10, 12 microns was left. And that's a very thin area. You can see it was very thin, small piece of lenticule, which was sticking right in the central area. That's because of the black spot. And after that, I just did a PTK, like a 30 micron PTK, just to smooth the surface, put back the flap and put a bandage contact lens. And this was the results. This is the pre-op topography. You can see the central steepening, and post-op you can see it is regular, and you see that central flattened area. And uncorrected vision was 20/20 parts, and patient was happy. So this is again, if you have a very small sliver, then it's very difficult to go in through the pocket and dissect this. You can't make out, even if you use triamcinolone, it may be difficult to kind of remove it when the pocket is there. But when you lift the flap, then it's easier. And this is the post-op clinical photography. You can see that it is very smooth, the interface, because I've done a PTK also. And we have also published this in JRS, Management and Outcomes of Retained Lenticules and Lenticule Fragments after failed primary smile. And it's a case series where we have put in different cases. And the video also is there under therapeutic refractive surgery if you all are interested in going through the details. So those are my two mystery cases of smile. Thank you very much for your attention. If there are any questions, I would be more than willing to answer.
Thank you, Sri, for those wonderful presentations. I would like to invite Professor Dr. Namrata Sharma and Dr. Kumar as the discussants. Namrata, ma'am.
So I think Sri Ganesh, very nice set of cases, and the mysteries were solved. The first case had a retained lenticule, and of course, as is advocated, you have to do anterior segment OCT if you have it, or alternatively, on the same day only you can address it if you have an intraop OCT microscope, because that will help you to delineate the retained lenticule in the interface, and you would know exactly where it is left. And like you said, that it was not a retained incomplete lenticule, but it was a retained complete lenticule. Another alternative, of course, this was done by a surgeon who's in the learning curve, but other alternatives also can be tried. For instance, triamcinolone can be put, or people have used even BSS. And one more thing that can really help, especially when your lenticule gets folded, is air. So if inadvertently sometimes air goes in, or even you can use sterile air, you can actually see the edge of the folded lenticule with the help of
Basically, there are three approaches for beginners if you want to identify the lenticule. One is always dilate the pupil. Dilate the pupil and take the patient on a microscope which has coaxial illumination. So if you have a fundus retroillumination, then you can see the margins. So that is one thing, dilate it. Second is you can use triamcinolone or even predacetate drops. You put it in the interface, it will stain the edge of the lenticule and delineate the lenticule, and then you can dissect it. Third is you can use air. If you put in air, then that air kind of accumulates at the edge of the lenticule, retained lenticule, because it's elevated there, and that will help you visualize. Fourth is you can use the slit lamp on the Visumax itself. So with the slit lamp, you can get a better view. And fifth is you can use an endo illuminator. This is also something that you can use. You put off the main illumination of the microscope, and then you put in a fiber optic at the limbus, and then you can see because of the sclerotic scatter, you can see the edge of the lenticule, and then you can dissect it. We have described this also. Of course, if you have access to ASOCT, then it helps. So I think many of the surgeons would, So these are basically the techniques for
tricks of identifying the retained complete or incomplete lenticule have been discussed. So very nicely managed case. About the second case, I would just say that astigmatism, that central island that you saw, even when we do lamellar grafts and we dissect manually, then also that irregular astigmatism is there. And so that is why it was there, and it was, it just highlighted the fact that the dissection is irregular there. So whenever you have a black spot, which is big enough, and you force your way through and dissect them manually, then this is bound to occur. I mean, it is forgiving for small amount of dissections, but not for the amount of black spots that were seen. So, and of course, very nicely through the circle, you just took out that part which was retained again, which did not get picked up on the AIOS because of the resolution of the AIOS, which is not that much to pick it up. But again, very well managed. I have one question. In your series of smile surgeries that you have done, what is the percentage of retained lenticules complete or incomplete by experienced surgeon vis-a-vis by surgeons whom you are teaching in your setup?
See, I have had only 2 cases of retained lenticule, which I managed. The second one was the case which I did, and the other one was there was a very thin, low power and thin lenticule, and then there was OBL at the periphery. So there was a peripheral lenticule, but I identified it with a slit lamp on table itself, and then I was able to dissect it. And then after that, for very thin, low powers and thin lenticules, I kind of add and keep it at minimum 20 or 25 microns thickness, so that it's easier, especially if you get OBL at the periphery, then that can make your dissection difficult. And after that, I've not had any. We have had quite a few cases referred to us for retained lenticule, and we have managed about 5-6 of them. There are few more very interesting cases, but because of the paucity of time, I couldn't present all of them. I just presented 2 of them and technique of management. So this is, in fact, I have one more doctor who got operated in London, and he's actually in Singapore, and he's just waiting for the COVID situation to get over. He has, I think, a retained lenticule. He had sent me all his case reports, so I asked him to come, and I'm going to explore and then remove the lenticule. Because one of the approaches that many surgeons would advocate is to do a surface TopoLink PRK. But I think this is the wrong approach, because there is a problem in the interface, and if you don't actually manage that and you're just doing a surface treatment, then that's not going to remove the irregularity completely. You may kind of regularize the cornea a little, the epithelium will compensate for it a little, but if there is a thick area of lenticule, then definitely the interface, there are going to be a lot of scatter and irregular astigmatism, and the patient is not going to be happy. So you need to kind of, primarily, if you can, explore and remove it. If the whole lenticule is in place, surgery being abandoned, and if you see the video and there is some problem with the video, like a black spot and all that, then don't go in and try to explore, because again, it's going to cause some irregular astigmatism. It's better to do a surface ablation. But if you review the video and if you see that the laser has fired properly, pattern is okay, then you can go in and then explore and remove the lenticule.
Sri, excellent presentation, and I think you answered all my questions, that you need to dilate the pupil, and Namrata said that it's better to do an online OCT, then you get a better view. What I wanted to ask you is that when we do all these dissections, I've realized that when you do more dissection, the visual recovery is not as good as what you do normally. So normally patients are 6x6 next day and everything is fine. There was a controversy, if you remember last time, that patients are 6x6 or not next day. So I know that if everything is very smooth, they are 6x6. But when you have to such a thing and you have to re-dissect and everything, so I just want you to bring to the notice that yes, that in such cases, what is your line of treatment and how much time do they become 6x6 or they never become 6x6?
See, if the surface is irregular, like the second case, because there were black spots, I knew that the surface would be irregular. So I combined it with a PTK, a 30 micron PTK, and that kind of regularized the surface also. See, one of the excellent tools to evaluate the interface is the HD analyzer, the OCAS, that gives you the amount of scatter. If you don't have an OCAS, then what you can do is you can dilate and do a retroillumination and retroillumination photography. And we have actually graded the interface, and it's published in IJO also, grading of interface. And in cases of difficult dissection, it may take up till 2 months for the interface to heal and come back to normal. But again, depends upon the surgeon and surgical technique. If there's not much of edema, and if you're able to remove the lenticule very easily, then most patients day one also are 6/6 parts or 6/6.
Thanks, Sri.
Thank you. Thank you so much. Any other comments from any other panelists?
The only thing that I'll wish to say is that if there is more manipulation, Kumar, what you said is absolutely right, that there could be a little more time for the recovery, but you pump up the steroids and go on to more potent steroids rather than fluoromethalone, and the patients would recover much faster. It's the manipulation which causes, as Shri said, the interface edema, and that obviously is going to be more if you have more manipulation. It's similar to doing more manipulation in a cataract surgery and things like that. So just pump up the steroids and go to more potent steroid topical drops. But
I have a question for Dr. Sri Ganesh.
As was mentioned,
No, triamcinolone acetate diluted is a great adjunct. We have published on it also. Truly delineates the lenticule revenant very well. And secondly, in that very interesting second case, he picked it up from the stromal surface. But in my experience, quite often it's stuck to the back of the cap also. So sometimes you go digging around in the on the stromal surface, but you might have to scrape it off the back of the back of the cap. And thirdly, for Kumar's question, I mean, if it's a small lenticule bed and you're able to remove it completely, which has happened in my hands about 3 times, you find that on the first postoperative day itself, the patient is almost back to normal. And the topography also completely regularizes. Of course, it has been a lot of handling, and many days later, then it's more challenging for the patient to recover the vision.
Actually, in the second case, I used an endoilluminator. I put out the microscope light, used an endoilluminator, and that's how I was able to spot this, because it was a very thin fragment which was there. Of course, it can also be stuck on the posterior surface, but if you look at the laser pattern, the black spot occurred while the refractive cut was being made. So most probably it was on the stromal surface. And most of the time, if during the refractive cut, if you have a black spot or some difficulty, it's stuck on the stromal surface. But of course, you should examine the undersurface of the flap also, and you can remove it if it's there. But mostly it will be stuck on the stromal surface.
Thank you so much, Dr. Ganesh. I think someone referring you the case for retained lenticule, I think they have to send the even video recording of the even treatment pattern also, I believe.
Yes. I always ask them to send me the videos, and you have to review the videos. Only then you can see, because if the pattern is not okay, or if the laser has not fired properly, then I would not take up for exploration. So this is a very important point which I made. Always ask for the video, primary video.
Chekitan wants to ask one question to Dr. Ganesh.
Yes, I just had a query, sir. The 30 micron PTK which was done, did it overcorrect the refractive error, or I mean, did the patient become plano post-op?
No, there was no hyperopic shift. See, if 30 micron is very small, and PTK basically does not cause much of a refractive shift. So that is not very significant. I just wanted to do a kind of a polishing of the surface so that it becomes a little smooth.
Thank you.
Thank you so much. I think